Hello and welcome to the group room where we're at the 34th annual CTRC-AACR San Antonio Breast Cancer Symposium. I'm very glad to be back with you, Professor Dr. Stefan Gluck. You are the Associate Division Chief for Clinical Affairs in the Division of Hematology Oncology at the Sylvester Comprehensive Cancer Center, the University of Miami Health Systems, where you're also the Clinical Director of the Braman Family Breast Cancer Institute and Professor of Medicine at the University of Miami. And you love your work in the area of breast cancer.
Absolutely. It's my professional life. I do everything and anything for my patients and for those who might be patients in the future.
Well, you also deal with a unique patient group in Miami, and that happens to be the Hispanic patient, of which there is some information being presented at this meeting, and the concern about breast cancer mortality being higher in Hispanic women.
Ethnic diversity, if you may call it, is a big issue, and this country is changing as we speak. Some people from the NCI who visited us last year said that Miami and its population is the model how United States population will look in about 50 years. So be prepared for these changes. How do we look today? Miami is a very transitional city. Many immigrants come through Miami, and they can be islanders, which includes, of course, Cubans from the 50s, 60s, but increasingly so other islands, including Haiti. So we have these populations, and they are completely different than Hispanics from South America or other Latin people like Brazilian. We have a huge and increasing immigration flow from South America and Central America, so the Cubans are not necessarily what people think they are. Miami is not Cuban anymore, it's Hispanic. And Latin, actually, including French, Haiti, Creole, and Latin. And we have a larger than a national average population of Black African American. I specifically say Black African American because we also have Black Hispanics and Black Latin, which is another thing. And finally, we have White African American. So it's not so easy to just say African American. The diversity teaches you also how to identify these subpopulations, if I may say. We also have a large population from elderly women or elderly people who are the so-called snowbirds, and they became part of Miami Beach, Hallandale, and southeast Florida. And of those, a huge population is actually Jewish Ashkenazi. Now, why is it important? Because all these subsets of people who we are seeing in Miami and area have a different risk for breast cancer than the average Western population. And it's the key here. Number one, African American, as you know, Black African American. Two, Jewish Ashkenazi. And now newer data, not quite new, but newer data are that Hispanics, which are the Spanish-speaking Latin people, may have also a different type of cancer. And what they have in common that these women, there's a very small proportion, 0.7% of male breast cancer also, is being diagnosed earlier in life than the average Western white Caucasian population that came from somewhere in Europe, which is about 63 years now. Both African American and Hispanics and Latin, they are being diagnosed in the late 40s and 50s or late 50s, so anywhere between 5 and 15 years earlier on average than we are diagnosing women who have the standard, if I may say, Caucasian background. And this already explains something. It explains two things. Breast cancer in younger people or women is usually differently distributed. It tends to be more frequently triple negative, or at least low on estrogen levels. Why? We're not sure, but I can tell you why the elderly have more estrogen. Because estrogen as such, and we heard it about the environmental talk yesterday, estrogen as such, exposure to estrogen over time, the longer it is, the more the risk of breast cancer is rising, but only for ER positive. So in a younger woman who is, let's say, 40, 45 years old, she didn't have so much estrogen like a 65 who had another 10, 15 years longer estrogen, high estrogen levels before she became menopausal. So this is one of the explanations. And also the estrogen may or may not be functional, so it does not produce or encode for the subsequent genes such as progesterone receptor and about 200 some other genes that are being activated. And now these are the cancers that are more aggressive. So this is the whole story going all the way back, and that's the poster or paper that we are referring to. Hispanics have more aggressive breast cancer, so do Black African American, and they have it actually less frequently than Caucasians. But if they get it, it's more aggressive and they die more. And that's basically the message of this paper that was presented.
So it's way beyond access to care or
Yes.
delayed diagnosis. It's the whole biology of the disease.
Correct, yes. Obviously, particularly in Miami, we have a fresh immigrant population, and the last thing on their mind is to do health. They need to get the papers, they need to get a job, and doing mammograms or even going to the dentist is not on highest priority.
Well, as we're speaking about the issue of the biology of cancer, and in particular these subgroups, maybe we can talk a little bit about the genomics of cancer and genomic profiling.
That's a great transition, because I think this is where the future goes. If I may say a silly saying, breast cancer is not breast cancer is not breast cancer. And it's, of course, estrogen receptor positive, negative, progesterone receptor positive, negative, and HER2 positive or negative. And we have known this, the estrogen thing, probably about 50 years. Actually, indirectly, we knew it since 1898, where Sir Beatson published the data that removing ovaries, which is estrogen deprivation, improves outcome in breast cancer. But he didn't know about estrogen receptor at that time, of course. More recently, 20 or so years, we know the HER2 receptors. But let me tell you, there's much more behind it than just these 3 markers. And you know, there's about 20 interesting markers. But I think if you look at the genomic profiling as we think we should be using it, there is a different genetic composition of the cancer cell in different cancers. And one of the pioneers was, of course, Oncotype, so genomic health. The other one was, on a completely different way, MammaPrint through Agendia. And in the meanwhile, we have probably half a dozen such tests available, many of them commercially available. The newest is PAM50, and there's a whole number of abstracts this year at San Antonio showing that PAM50 identifies what we called the Chuck-Perouse intrinsic subtyping, the molecular subtyping, the so-called luminal A and B, the so-called basal, the HER2 enriched, and probably also Claudin low, and maybe to a lesser extent normal-like, but it turns out the normal-like really are normal tissues. And these molecular subtypes behave completely differently. They correlate loosely with estrogen and HER2 receptors, but only about 70 to 75%. And I think with this new knowledge and the targeted therapy that we heard from many, many other speakers today and yesterday and will tomorrow, we will identify subtypes, molecular subtypes, that will be actually the real target. It won't be one target like the mTOR or like estrogen on combination of 2 or 3. My prediction is it won't. It will be a whole array of genes that we have to target.
Thank you, Dr. Gluck, Associate Division Chief for Clinical Affairs at the Sylvester Comprehensive Cancer Center, University of Miami, Professor at the University of Miami School of Medicine, and Clinical Director of the Braman Family Breast Cancer Institute. Thank you always for making time. I love your passion.
Thank you, Selma. It is a pleasure to be here.